want to call our meeting to order of Subcommittee Number 1, Health and Human Services. For good exercise, we'll call the roll.
Yeah, there you go. Weber.
Here.
Chesbrough. Here. Dickinson. Grove. Mansour.
Thank you very much. We're going to begin our committee hearing today. This is with the Department of Public Health, and we're going to issue one, which is an overview of the department. So we're going to call forth those who are scheduled to do the overview of the Health and Human Services Department. Thank you.
Should I begin?
Yes, please do.
Thank you. Good afternoon, Chair, Committee. My name is Dr. Ron Chapman. I'm the State Health Officer and Director of the California Department of Public Health. Thank you very much for inviting me to present. Senate Bill 162 reestablished the California Department of Public Health in 2007. Our department employs approximately 3,500 people in over 60 locations around the state and administers a proposed budget of $3 billion. Our mission is to optimize the health and well-being of the people of California. Of the proposed budget of $3 billion, 23%, or $638 million, is for state operations, and 77%, or $2.3 billion, is for local assistance. This is an 11% decrease compared to fiscal year 13-14 Budget Act. And the vast majority of this reduction is due to the proposed transfer of the drinking water program and the environmental lab accreditation program to the State Water Resources Control Board, and a proposed reduction to WIC local assistance due to lower food costs resulting from USDA's directive to lower reimbursement rates for small stores. The department works to keep us all safe and healthy through the delivery of quality public health services. We rely on public, private, and community-based partners at the state, local, national, and even international levels to help us accomplish our mission. We achieve our mission through the following core activities. We monitor health status to identify and solve community health problems, such as our safe drinking water, food, drug, and medical devices safety programs, and infectious disease monitoring. We track vital statistics such as mortality and variety of chronic diseases. We work very closely with partners to address health problems and health hazards in the community, such as our work to prevent infant deaths and premature births, which are now at historic lows. However, it's important to point out there are still huge health disparities that exist in those areas, and support for the highest risk moms in this state continue to decline. We inform, educate, and empower people about health issues such as our breastfeeding, education, and tobacco education campaigns, and we promote public health policies that support individual and community health efforts, such as a successful partnership in 2011 with local public health departments, education, the healthcare system, and the legislature to control the largest pertussis outbreak in 50 years. We enforce laws and regulations that protect and ensure safety, such as the licensing and certification of health facilities and many of their personnel. And we link people to needed personal health services and assure the provision of health care when otherwise unavailable, such as through our AIDS and HIV programs. Lastly, we prepare for public health emergencies such as wildfires, drought, earthquakes, and large-scale infectious outbreaks with all of our local partners, including hospitals, schools, businesses, and local public health departments. We strive to maximize all of our existing resources. We need to be an effective and efficient organization in order to deliver high-quality public health services, and we do this as an executive team through a systems approach. We have completely revised our internal contracting process, for example, and are considered a model in state government. We've led the way in state government in zero-based budgeting, which improved the business operations in several large programs, including our Women, Infants, Children program. And we have a strategic plan which has cross-cutting strategic objectives, such as make continuous quality improvement a way of life in the department, achieve health equity through public health programs, and expand and strengthen collaborations and partnerships. I began this job with a vision of achieving national public health accreditation, which involves systems improvements to meet 105 nationally accepted measures. And after an 18-month process, just last month, we submitted documentation of our efforts to be reviewed by a national team from the Public Health Accreditation Board. The benefits of the accreditation process have been many, including a modernized workforce development plan, the creation of the department's first ever quality performance plan, and a quality improvement infrastructure, including QI teams and a quality performance committee. Public health is all about preventing disease and keeping people healthy and safe. Thanks to the Let's Get Healthy California work, we have a vision of California being the healthiest state in the nation by 2022. To achieve this vision, we need to reverse the trend of increasing obesity in adults and children. Unfortunately, physical activity levels remain low, and the consumption of unhealthy foods and sugar-sweetened beverages continues to be high. Neighborhoods and communities should be designed to promote physical activity, and we need to increase access to healthy foods and beverages. Nearly 40% of Californians live with at least one chronic disease, and almost 60%, or $51 billion, of California's healthcare expenditures were for people with multiple chronic diseases, which are largely preventable. Health inequities exist across all chronic diseases, and we are striving to include a health lens in policymaking through Health in All Policies work. The work focuses on underlying risk factors, such as tobacco use, physical inactivity, and poor nutrition. And these factors are largely influenced by the communities in which people live and the social determinants of health, such as education level, employment status, and poverty. Infectious diseases such as tuberculosis, valley fever, hepatitis C, and sexually transmitted diseases continue to threaten the health of Californians. Our infectious disease work relies heavily on public health laboratory testing in our department's Richmond campus and in county public health laboratories across the state. These labs play a unique role in testing and surveillance, which hospital labs and private labs do not perform. The backbone of public health in California is the partnership between local public health departments and the California Department of Public Health. Public health is only as strong as this partnership. And much of our surveillance, outbreak investigations, emergency preparedness, and program implementation are accomplished in collaboration with the 58 county and 3 city local health departments. When I walk down a street, I see public health in action everywhere I look. Streets designed to encourage walking and biking and reduce pedestrian injuries. I see children wearing helmets while biking. I see babies and infants safely buckled in car seats. I see children who have been vaccinated against infectious diseases which 100 years ago would have taken their lives. And I do not see people smoking in restaurants. We have accomplished much in public health in California, but the work of public health never ends. In 2009, for example, public health responded to the H1N1 flu pandemic, and in this flu season, H1N1 continues to dominate and cause deaths. And we're fortunately armed with a vaccine to prevent these deaths. E-cigarette use is growing exponentially and threatens to undermine California's anti-tobacco successes, which have to this date saved over 1 million lives. The future success of public health in California is dependent upon a strong partnership with local public health, healthcare systems, and community-based organizations, a robust public health workforce, and support from local, state, and federal governments. I just want to end by thanking the thousands of California public health workers who have dedicated their careers to protecting and improving the health of the people of this great state. Thank you.
Thank you. Any comments from any of the others? Overview. Any questions from the panel? Not, then let's move on to issue number 2, which is the AIDS Drug Assistance Program, ADAP.
Good afternoon. My name is Dr. Karen Mark, and I'm the Chief of the Office of AIDS at the California Department of Public Health. Do you want me to start with a summary? So for fiscal year 13-14, the enacted budget includes ADAP local assistance funding of $406.3 million with no state general fund appropriation. The revised fiscal year 13-14 budget is $419 million, an increase of $12.7 million, mainly due to reduced savings estimates of reimbursement for drugs dispensed to ADAP clients who were identified as also being enrolled in the low-income health program. In spite of this budget increase, the proposed budget does not contain a general fund appropriation, nor any cuts to services, because ADAP will use all rebate funds available in fiscal year 13-14 due to the Federal Health Resources and Services Administration, or HRSA, mandate to spend rebate funds prior to spending federal funds. ADAP requests an increase of $46.4 million in ADAP rebate fund expenditure authority, mainly because of this federal requirement, but also because of an increase in the drug rebate percentage rate from 60 to 65%. In addition, ADAP requests an increase of $24.3 million in federal fund expenditure authority due to additional grant awards received, and will return $58 million of reimbursement funds to the California Department of Health Care Services when compared with the 13-14 Budget Act. For fiscal year 14-15, proposed funding for the budget year is $409.6 million. The decrease of $9.4 million compared with the revised current year is mainly primarily savings from the Affordable Care Act programs, including Medi-Cal expansion and the movement of clients into covered California. Changes to ADAP's budget authority when compared with the revised current year budget include the following: an increase of $42.8 million in reimbursement funds, a decrease of $4.8 million in federal funds, and a decrease of $47.5 million in ADAP rebate fund expenditure authority. As always, the numbers in the estimate will be revised with updated information during the May revise. There are no new major ADAP policy changes with substantial fiscal impact that are included in the proposed budget. A small increase in ADAP pharmacy benefits manager costs is included, $103,000 in fiscal year 13-14 and $220,000 in fiscal year 14-15 due to programmatic changes to implement the federal HRSA mandate of 6-month ADAP client eligibility recertification. The fiscal year 14-15 governor's budget proposes creating statutory authority that will allow the California Franchise Tax Board to share tax data with the Office of AIDS. The availability of tax data will complement existing Ryan White Part B, including ADAP enrollment practices, as OA will be able to cross-reference Ryan White Part B client data with tax data. We assume potential fiscal costs and savings impacts will be absorbable in 14-15.
Okay. Thank you. Any questions? Any additional comments from Finance or LAO?
Amber DG, Legislative Analyst Office. While we don't have any concerns to raise about the ADAP estimate, we note that in the past, ADAP has received general fund support. Over the past 10 years, it's ranged from a high of $107 million to a low of approximately $5 million. In 2014-15, ADAP estimates using over $50 million in safety net care pool funds, which offsets general fund. These are federal funds that are received through the Medi-Cal Bridge to Reform waiver. This waiver expires in the fall of 2015, and while the waiver is likely to be renegotiated, the receipt of continued safety net care pool funds is uncertain. Therefore, there may be the need for future general fund support of ADAP.
Okay. Any other questions, comments? Any comments, questions? Okay, thank you very much. We'll move on to item number 3, which is the Ryan White Data Match Program proposal. Okay.
Sure. So we believe that the ability to match Ryan White data with Franchise Tax Board data will make the ADAP and OA HIP recertification process more efficient. We currently verify client income eligibility for our federal Ryan White programs through a variety of client provided documents, including pay stubs, support or self-employment affidavits, bank statements, or tax returns. We do not require tax returns to document income for Ryan White eligibility purposes because some Ryan White clients earn so little that they're not required to file tax returns, and hence they may not file them. If this cross-match of Ryan White client data with FTB data is approved, this policy would not change, and clients who do not file tax returns but provide other documentation showing that they earn less than $50,000 a year would remain in Ryan White programs, including ADAP. We are planning to require tax returns for OA HIP clients who are enrolled in insurance plans purchased through Covered California starting in 2015. This is necessary because reconciliation information regarding the advanced premium tax credits for insurance purchased through Covered California will be present on these tax returns. We feel that the ability to obtain FTB data electronically through a data match rather than requiring clients to share with us paper copies of their tax returns will substantially ease both client and enrollment worker burden at recertification time. Clients identified through the data match with an income above the eligibility limit would be required to provide documentation proving that their income had decreased below the eligibility limit. Otherwise, they would be disenrolled from Ryan White programs. The primary reason for proposing this cross-match is to make the recertification process more efficient for both clients and for enrollment workers. However, we also acknowledge that the current system of verifying income for ADAP and OAHIP clients does leave open the possibility that some clients on these programs could earn more than $50,000 a year. For example, in lieu of providing tax returns, a client may provide pay stubs for only one job when in fact he or she may have a second job that brings his or her income over $50,000 over the eligibility limit. Obtaining FTB tax data would enable us to confirm that such a client is not actually eligible for ADAP or OAHIP. We don't believe that obtaining FTB data would lead to the disqualification of a substantial number of ADAP clients, although we have no way of knowing this for sure until the cross-match is implemented. We have not estimated savings from this proposal because we have no way of estimating the number of ADAP clients who might be disqualified until the cross-match is implemented, and because we believe that the number of such clients who would be disqualified is likely small. If this policy is implemented and if it does subsequently result in non-significant savings, then this could be addressed in subsequent estimate packages.
Okay. Any
Madam
comments
Chair,
from LAO?
Madam Chair, may I ask a question?
Yes.
So would this be voluntary? Would the person be asked would they need to give permission for allowing their tax information to be accessed?
I think that as part of enrolling in the program, they would have to give permission for their tax information
Is
to be
there
accessed.
precedent for us doing this with other programs?
Yes, there are other programs in the state who do this. We just don't have that authority at the Department of Public Health for this purpose.
Any other questions? Okay. Do we have any public hearings on this item or the one before, in case we missed some folks for public hearing? Public testimony? Okay.
Hi, I'm Ann Donnelly with Project Inform. Thank you very much. I think our concern about this is not so much perhaps in the long run, but certainly in the short term. The accuracy of those data and, in addition, the necessity to match it up with what people are actually making, I think is critically important. So if something like this is going to be done, we would propose that at a minimum there's a long sort of phase-in period during which time you'd be able to check those data and ensure that you weren't excluding anyone from the program based on data that was incorrect or not up to date.
Okay.
Thank you.
Thank you.
Beth Capel on behalf of Health Access California. The use of tax data is something that is relatively new to health programs. Research done by the University of California at Berkeley indicates that a very substantial share of individuals have changes in their income over the course of a year, and thus tax data, which inherently lags by 15 to 24 months, is often inaccurate. We are not opposed to necessarily the data match, but there need to be systems in place to allow for circumstances in which someone has lost a job, gotten a raise, any of the other many things that would affect their income. This is a problem in other programs as well, including the Medi-Cal program in Covered California, and one that we are currently dealing with there, and it would be an important one for this program to take into account as they move forward. Thank you.
Madam Chair, I'd just like to agree that that raises some questions about making sure that somebody doesn't wind up inaccurately being rendered ineligible. So certainly we want to see those questions answered.
One of the questions I had was this. Do we feel that the Office of AIDS is not capable of certifying individuals, that they don't have the tools to do that, and that we have a problem that exists that this is going to solve? I'm trying to figure out, do we have, what's the issue, what's the real problem that we have? Are we under-identifying or over-identifying individuals that are draining resources, or exactly what?
Well, we're really primarily proposing this because we feel that it'll be more efficient for both clients and enrollment workers, because if we can basically verify income electronically rather than requiring clients to go back to their files, of which they may have lost since they last did their tax returns, and basically drum up documentation of their income. That is one of the things clients basically complain about as part of enrolling and recertifying in the program, that they have to provide documentation of their income. So we think that it will make the recertification process more efficient for clients.
Okay, I'm not sure if most of us would want an agency digging in our tax accounts. Most of us have to dig up stuff for loans and grant, or whatever we have to do. I'm not sure if I'd sign off for some loan on a house or something to start going into my records. I mean, it's just, I'm trying to figure out what the problem is. If it's a matter of that we think people are, that we have a problem to solve, that people can't go get their last paycheck stub or whatever it is. But it just seems like an invasive kind of thing, and I think as we move more and more into an understanding of how much invasion there really is into our personal information, it makes people a little bit concerned, I would say. So that's why I was trying to figure out what the problem was, that we have this over-identification or under-identification, or, we're trying to solve a problem. If it's people not wanting to find their forms or can't find them, and maybe this is an option, but not a practice. In other words, if people come forth with their statements, then maybe they don't have to engage in this thing with the Franchise Tax Board. If they can't and they need services, that may become an option rather than a practice. That's what I'm trying to figure out, what we're going to do about it. So it's something to think about. Any other comments? Okay, I think, thank you.
Madam Chair?
Yes.
Kimberly Harbison, Department of Finance. I'd like to address your concern about that. They would have to maintain confidentiality, as they do with all other types of information. And also, the match would be purely data-driven. It would be through the Office of Technology. There wouldn't actually be a person looking at this information. It would be a straight hit, it matches or it doesn't,
Okay.
based on a unique identifier for each client.
Okay. I would like to believe that, and it may be true.
I think that's what the target customers thought.
Yeah. It might be very true.
That's the intended design.
Yeah, I know the intent, but I'm just saying, we've had so much breach of confidentiality, and I thought that was true at Target too. So, but and then I discovered, they know my last name and first and all the names in between. So. I'm just curious as to whether or not this becomes an option rather than something that's mandated if we start collecting more and more data on individuals for health care. It just seems to grow. I think that's a concern that I have. And I'm just trying to figure what the problem is. Okay, yes.
Thank you, Madam Chair. It would seem on the face of it that the information would at best be dated 5 months after the income year, right? And so you said there are, we have done this, or the state has gone down this path in other cases. I think if we're coming back to consider this at a subsequent hearing, it would be good to have some information on the efficacy of the use of this approach in other instances, because I think we all have reservations about privacy, and so there. Information that would indicate this is of some specific and significant value, I think would be important to offset those concerns about privacy.
Okay. Thank you. So as you come back, this item obviously it's not going to be acted on today. It will be held over, but as it comes back, hopefully we'll have some examples of where we've done this before and how effective it's been. Thank you very much. We're going to hear item 4 and 5 together. I think 4 and 5 are going to be presented by LAO. Is that right? And ADAP eligibility and family size, and the Office of AIDS health insurance premium payment proposal. Thank you.
According to the agenda, advocates have submitted a proposal to adjust eligibility for the Office of AIDS Health Insurance Premium Payment Program, or OAHIP, and ADAP. Currently, the financial eligibility cap is federal adjusted gross income of $50,000, regardless of household size. This proposal would change that to a cap of 500% of the federal poverty level, which using 2013 data is $57,450 for a single individual and $97,650 for a three-person household. We note that many other states use the federal poverty level to determine eligibility for ADAP, although some states also have an asset limit. And also in California, other health and human services programs account for household size in determining eligibility, such as Medi-Cal, CalWORKS, and CalFresh. We just received details about this proposal on Friday afternoon, so we're not able to provide cost estimates at this time.